Hi, my name is Alexandre Jaccard and I'm from Avaré, Brazil. I have no conflicts of interest. The learning outcomes is to measure and interpret spinal alignment and spinal pelvic parameters, and work with a surgical planning tool and apply simulation to see potential outcomes. A case example of a male of 36 years old, an orthopedic surgeon. He has low back pain and sciatica and a sensory deficit of L5 and S1 right roots, and an odds of 36%. The question is this patient well balanced? We have some concepts. The equilibrium is a state in which opposing forces are balanced, and the spine should be in equilibrium with the less effort possible. In 1994, Dubuisset described the concept of efficiency conus. You may see the image on the right that the central part of the conus is a cylinder and represent the relaxed position. The larger the base of the conus represented by the head, the greater the effort the muscles to rebalance and maintain equilibrium in the upright position. The upright posture is represented by a set of articulated body segments: the head, the spine, the pelvis, and the lower limbs. We know that we have morphological differences in the pelvis that play a role in posture of the spine and as a consequence the equilibrium. So let's take a look in the pelvis. The pelvic parameters were described by Duval-Beaupre in 1992 and then in 1998 by Duval-Beaupre and Legay. They are the pelvic incidence, the pelvic tilt, and the sacral slope. The first pelvic parameter to be considered is the pelvic incidence. The pelvic incidence corresponds to the angle between the line connecting the axis of the femoral heads to the center of the S1 end plate and the perpendicular of the S1 end plate. The pelvic tilt is the angle between the vertical line and the line connecting the center of the sacral end plate to the axis of the femoral heads. And the sacral slope is defined by the angle between the S1 end plate and the horizontal line. The pelvic incidence is equal to the sum of the sacral slope and the pelvic tilt. Just mathematics, they are complementary angles. Of paramount importance is to understand that PI, pelvic incidence, is an anatomical parameter. It is constant. It is the orientation of the sacrum inside the pelvis of each individual, fixed by the sacroiliac joint. It means that no matter how you rotate your pelvis, it will keep the same. So let's take a look in these three different pelvises. Note that each one has a different anatomical position inside the pelvis. As so, each one has a different PI. And as a consequence, observe what happens with the sacral slope in the low PI and the sacral slope in the high PI patient. And also how it influences the spine. The patient with an average PI tends to have an average low lumbar lordosis. The patient with a low PI has a verticalized sacrum with a low sacral slope and tends to have a smaller lumbar lordosis, a flat back. And the patient with a high PI and as so high sacral slope naturally needs more lordosis to keep the same upright position. So, the relationship between pelvic and spinal parameters is essential. The lumbar lordosis is measured between the S1 end plate and the inflection point when the lumbar lordosis turns to the thoracic kyphosis according to Risoli. In 2005, he published the classification of the normal variation in the sagittal alignment of the human lumbar spine and pelvis in the standing position. They described four types of sagittal alignment based on the sacral slope. Type 1 and 2 are characterized by a small sacral slope, less than 35 degrees. The Type 3 is the sacral slope between 35 and 45 degrees, and type 4 the greater than 45 degrees by definition. The type 1 combines a very short distal lordosis with a thoracal lumbar kyphosis. The type 2, 3, and 4 are the classical patients with a low, average, and high PI respectively. Another principal concept is the distribution of the lumbar lordosis. In 1998, Jaccard proposed that the shape of an ellipse would fit the lumbar lordosis. That means that two-thirds of the lumbar lordosis is located between L4 and S1 and 85% of between L3 and S1. This is very important to keep in mind because when we have to fix the lumbosacral region, we should always pay attention to have a solid and lordotic foundation. And what about the compensation mechanisms? Are there any differences depending on the grade of the PI? Yes. Let's look at the outsider morphologies to better understand. The pelvic tilt and sacral slope are positional parameters and change by the movement of the pelvis around the femoral heads. This movement can be forward, that is anteroversion, or backwards, called retroversion. A patient with a high pelvic incidence has a greater potential for pelvic retroversion. The pelvic tilt angle will increase and the sacral slope decrease. The higher the value of the pelvic incidence, the greater the retroversion can be. But look at the low PI patient on the left image. He has already a vertical sacrum, and that's why he has less potential for compensation inside the pelvis and uses other mechanisms of compensation. Inside the pelvis, the unique mechanism of compensation is retroversion, but compensation can occur in other segments of the spine. As seen in the L2-L3 disc space in the figure, an adjacent level hyperextension with or without listhesis may be found. The thoracic kyphosis can be reduced with extension, mainly in young individuals with strong paravertebral muscles, and the cervical spine may be hyperextended in order to maintain horizontal gaze. Another compensation mechanism is the knee flexion and with ankle extension, which usually happens after maximal pelvic retroversion has been reached. After this, malalignment will occur. So, how is the assessment of the sagittal balance? First of all, we must pay attention to the lateral radiographic positioning. The patient should stand upright with the knees extended and the upper limbs with 30 degrees of passive flexion with the hands on a support. The next option with less influences in the parameters is the active flexion of the shoulder and elbows with the hands on the clavicle. But look for the global alignment. The SVA is the horizontal offset from a plumb line dropped from the center of C7 to the posterior superior border of S1, and it's correlated with clinical outcomes. The normal value is plus or minus 2.5 centimeters. When the SVA falls in front of the femoral head, the spine is malaligned. In this example, we have a patient with an ankylosing spondylitis with a 10 centimeters of SVA, the plumb line falling over the femoral head. Is this real? Look at the inclination of the third proximal femoral shaft. When we correct this inclination, we find that the real SVA is 35 centimeters, and here is the clinical picture. So the SVA should not be evaluated as a single parameter because of the compensation mechanisms. For individuals with an average or high PI, retroversion of the pelvis is the first mechanism with an increase of the pelvic tilt seen in our ortho colleague with a pelvic tilt of 21 degrees. When we correct the pelvic tilt to a predicted value, look what happened with the SVA increases to 11 centimeters. So our patient is not well balanced. If you want to measure just one parameter, an option is the T1 pelvic angle, the TPA. It is measured between the same line connecting the center of the S1 end plate and the femoral heads, and the line connecting the center of the femoral heads uh, to the center of T1 body. The TPA does not account for pelvic incidence value, but remember that compensation inside the spine segments will change this value. The TPA target is less than 14 degrees. Our colleague is at the limit that I would not expect for a young patient. In 2018, Alfredo Giroy and colleagues did a study of the normal values of an Argentinian population. After the global alignment, look at the PI and lumbar lordosis harmony. In 2009, Schwab proposed that PI should be lumbar lordosis plus or minus 9, and if not, a mismatch is present. But this formula has a poor accuracy, especially for the low and high values of pelvic incidence. In 2016, Lehuec proposed a new formula for lumbar lordosis that is shown on the screen. For our colleague, the predicted lumbar lordosis will be 33 degrees and the pelvic predicted value of 9 degrees. So let's take a look in clinical applicability. Our patient failed conservative treatment and have a 30 percentage of spondy with a 47 degrees of PI. That means a low-grade spondy type 2 according to the classification. For the surgical planning, could we do an in-situ fusion? Should we reduce the listhesis or increase the lordosis? If we perform an in-situ fusion, this will not change the PT and TPA. So for this specific patient, the surgical goals should be to keep SVA, to increase lordosis, and decrease the pelvic tilt to approximately 9 degrees, or at least less than 12 degrees, and have a TPA less than 14 degrees. So the first thing to do is increase lordosis. But how much? And would it correct the pelvic tilt and the TPA? So let's plan. It's very useful to have a surgical planning tool. I like SurgMap, available for free download on the web. First, one should correct the pelvic tilt to the desired value. So you're seeing the pelvic tilt of 9. Then you have the surgical tool on the right of the image, unslip. So just let's zoom to have a better drawing of the end plates. First, the superior or the inferior end plate of the superior vertebra, and then the superior end plate of the inferior vertebra. You see the percentage and degrees of the slippage. I'll just close it to take out the zoom here to have the whole spine in the screen. Okay, so let's take out this and right click button and let's correct something. So I start with increasing the degrees of the segment. Look, the image, and I'm going to 4, 5, 6, 7 degrees. We have the SVA coming back already over the sacrum, and then with 30 degrees. And we can also take out correct some slippage. I'll just put it from about 10%. And that's the final figure of our planning. Surgical planning, so it's to increase lordosis about 7 to 12 degrees and decrease the pelvic tilt SVA and TPA. My surgical plan is to increase by an 360 orthodesis. First of all, I did an A-lift and then a standing film with the patient where I saw that the lumbar lordosis already is 57 degrees. So I thought it was enough, and 1 week later I did a posterior stabilization with percutaneous screws. And here's the post-op evolution. He has a 2 years follow-up and now an altitude of 2%. Here's the bibliography. As take-home message, look at lumbar lordosis as a consequence of pelvic incidence and pay attention to pelvic tilt and compensation mechanisms. Measure spinal alignment and seek for spinal-pelvic harmony. Use surgical planning tools for every arthrodesis cases. Thank you.